training. I am Ira Farley, and I'll be your host during our training session. For our technical support, Kamisha Busby will be assisting. Before we get started, we would like to Before we get started, we want to check in and provide a few reminders. This session is being recorded. For better audio quality, please remember to mute your mics on your computer or your phone when you're not speaking. Handouts for the training have been distributed to registered participants before the training. If you have not received them or are in need of handouts, please email mchtraining@health.ok.gov. Again, that's mchtraining@health.ok.gov, and they'll be sent to you. Handouts provided include the agenda and copies of the 2 presentations in handout form. During the session, feel free to ask questions during each presentation at the discretion of the presenter. At that time, if you can unmute your mics. If this is not an option, we have a chat feature within the meeting application. Feel free to use this option during each presentation as questions arise. Each presenter will allocate time during the presentation to address those. And our presenter has already requested that we field the questions for her so that she can focus on the presentation. And Kamisha will be attending to the comments and questions that are posted. As a reminder, attendees are to complete verification of attendance by way of the individual sign-in sheet, the sign-in form located on SharePoint. The link to access the form will be placed in the chat. For our contract agencies or clinics, OCCHD and TULSA, please see your program leads for the sign-in sheets. Let's welcome Cinda Lebus from the Women's and Men's Health Services Clinic out of the Coastal Bend in Corpus Christi, Texas, as our presenter. Cinda will share information about engaging males in reproductive health settings. She will focus on 1, review and development and process of a grassroots level campaign to engage males in family planning clinic services that she has been involved with from the beginning back in 2019.
1999.
So, I'm sorry.
That's
yeah,
okay.
Sorry. Yeah, 1999. Thank you. Since 1999, when it was Planned Parenthood is what she was working with. And she'll go into those details on the history of that. And she's been with at the same place all these years. So she's seen the whole transition and where they're at today. And the second part, we will discuss lessons learned and brainstorm ideas for replicating similar effects at the local level here in Oklahoma City and throughout Oklahoma in the urban as well as rural locations. Thank you, Cinda, for joining us today. The time is yours.
Thanks for having me. I'm really excited to be here. After COVID, we've had limited amounts of time to really reach out and talk to large groups. So I'm excited to virtually meet everybody. I have a PowerPoint. Are we okay and set to go?
Yes.
I'm going to go ahead and share that. Okay. My entire screen, and there it is, share. Okay. So just let me know if everybody can see that.
We can see.
Okay, great. So my name is Cinda Lebus, and I have been working for this agency since 1999. I'm a community health educator for our agency. And so I've been through a series of, it's been a metamorphosis, if you will, over the years. I'm just going to quickly walk you through our agency and its history so that you know. The clinic has been here since 1958 in Corpus Christi, Texas. And it was opened by some clergy members here who thought it was really important to have family planning clinics. We were a Planned Parenthood to begin with, right from the beginning. When I came to work here, it was a Planned Parenthood. It was called Planned Parenthood of South Texas. So we were just a very small affiliate, a local clinic. We just happened to be part of the Planned Parenthood Federation. It was under that heading that when I came, they had some local donation money, some foundation money that asked us to kind of really reach out and start to do awareness and outreach in the community for men, and get male involvement started that way. But it was in 2003 that our agency was given a research grant. It was a 5-year research grant, and it was to really track the number of males through our clinic. And so when we started in with that, that took us 5 years of data collection, of setting up ways of tracking. And that's truly where a lot of the funding went. It was to the research element, not necessarily to the operations or the clinic itself. After that, we had 3 more years. We got general funding to continue and to maintain male services. And then we had 7 years of just our administration, and the director of the male program at the time. They went out and they were able to consult with and help other clinics and do the work with them that they needed to try to bring up some of their clinics to speed. Somewhere in all of that time period where we're working with the male project, in 2010, we personally, as our own small clinic, family planning clinic here in Corpus, we made the decision to separate from the Planned Parenthood Federation. And at that point, we became just our own independent family planning clinic here. Their business model was going in a different direction. They were starting to enlarge, the small individual affiliates would be massed up into larger regions for reasons internally. We separated from the Planned Parenthood organization. At the beginning, our first new name under our own banner was Family Planning of the Coastal Bend. It was very short-lived. It was transitional, and it really didn't. It wasn't helping us in our goal, which was to combine male and female services and get men involved. So within a year, we realized we really needed to incorporate that right into our name. And so our agency now has been since 2011, Women's and Men's Health Services of the Coastal Bend. We felt like that was the only true way to get to where we were really going from the beginning of our male project. Sorry about that. So where we started, I'm just going to jump right in because I know that we don't have a lot of time, and I want to offer enough time for discussion. But I do want you to know, when we started, we were a Planned Parenthood. Planned Parenthood's name is very well associated with women's health. And so it was very difficult to branch out or send the message that, yes, we also see men. So when we started this whole idea of reaching out to men, we had to assess ourselves. What message were we sending? What image do we present? What do people see when they come into our clinic? We looked right down to our mission statement, agency policies, medical forms. They all had to kind of incorporate male involvement in a clinic setting, in an actual clinic visit. How would it go? Agency literature, brochures, all of the educational material that we had to really look it over and say, is any of this useful, or does it resonate with men? We looked at our staff makeup. We absolutely had, well, I think when I got here, we had one male on staff, and he was the male outreach educator. And he really just did community outreach. And so we started to look at, who would take on this research project and who would become the spokesperson for this whole concept of male. So we did hire a male for the director of the project. He's no longer with us, but he did a phenomenal job while he was here. He took it to heart, and he really ran with it. We looked at everything, all of the things you see here on your slide. The physical environment in our facility had to be really assessed. We looked at how the front desk procedures were, just checking patients in, the flow of getting patients through. Did it work for males? And then the protocols of how clinic services were done and how lab services were handled and things like that. So that's just our basic starting point. So I would like to kind of break every so often here, if you don't mind, to just offer you a time to give me feedback, or to give each other really feedback. I won't be here after today, but amongst yourselves, I think that you all have many answers. You have different solutions. You have lots of ideas. And I think that brainstorming here in this setting can really be helpful. So I think we're going to use the chat area, if you don't mind. And I'm going to offer you a task, a question, and I'd like all of you to really think it through and provide the answers in the chat room. Kamisha, you can read some of them out. You don't really need to, I don't think, we don't have to hear them all, but it might be a good idea if we kind of hear from everyone. So here's the first task, okay? Making a quick off the top of your head assessment of your own clinic, wherever it might be. I know that your clinic might be in a rural setting. It might be in the middle of a city. You might be a large facility or very tiny facility. But I think we all kind of start from the same place, and we can all do what we can do, right? So starting with your own agency where you are, what are some of the things you could think of right off the top of your head that you would consider right now they'd need to be male friendly, tweaked a little bit? What kinds of changes, where would you start to look at things within your agency that would have to be updated, reworded, bring in new resources, change environment, whatever you can come up with? I'm going to give you a minute to kind of just do that. And Kamisha, if you want to just let me know if things kind of, or let everyone know as things come in, what's being said.
This is the time for everyone to either unmute or add into the chat.
Sorry about that.
Yes, or put it in the chat. Some of the changes, the questions being asked, what are some of the changes that your clinic has done to make it more male friendly?
Or still needs to do, right? Just anything that you see that we really haven't thought about it before, and we've always been this way. And you know what? Now that I'm thinking about it, maybe a male wouldn't find this so comforting, and maybe this is a little off-putting, or maybe we should reassess our literature library. Any number of ways in which we can incorporate male images, anything at all.
So far, we don't have anything in the chat.
So I'm either going to assume that everyone has done that type of a self-assessment. Maybe everybody's already kind of gotten to that stage where you've tried to do all of that. So we'll just move on.
Okay, wait a minute. Here's one. One says public information, posters, and literature library appears to be predominantly geared towards the female or child. So I think that's the issue.
And I feel like we had to do quite a bit of researching on where we could find more literature that dealt with male issues. And I will tell you that there, I have them right here. I can show them. Can you see my slides, right?
Yes, we do.
If I come back here, do you see me?
I see your screen, yes.
Okay, can you see? I'm just letting you know that we have come up with lots and lots of male brochures and topics that that will resonate with men, male health, STDs. Obviously, that's one of their major issues in a reproductive health service. So we made sure to have plenty of that around. But the male images that we have in that literature and health, I think she's right, or whoever posted that, he or she is right, that your literature, that's what goes out into the community, and that's what people see. They start to just get a very subtle message that, oh, this is for men too, right? And that is just really where we start. Absolutely. Okay. I'm going to move forward to this next slide. So for us, and I can only explain our strategy and how we did it. And I know every clinic can only do what they can do based on who they are. But ours was to start with one mindset, like to get our head around one message about male involvement. And that was that we needed the whole community to shift their thinking, not just us, not just internally, not just once people came in through the door, but everyone, not just men. We really needed to think of how important that role was, that men be served for reproductive health. The fact that we want healthy relationships, we want healthy families, they make healthy communities, that basically it starts with a whole mindset for a community involving the men in this process. So we wrapped our head around that, and then we really needed to be sure that our whole staff actually bought into that message and that we all saw ourselves as really starting something big in our community, that this campaign with getting men involved was really going to be our way of changing the system or changing the process. So we really got excited about it. We really needed to be excited about it. Again, our director, Efren Franco, at the time, he was really able to kind of encourage us and get us enthusiastic and really challenge us. After the mindset, then the operations, these were like our strategies. These were the focus points of what we were going to do with our project. We started with getting focus groups together so that we could get word from men. We needed to hear from them directly why they weren't coming. Created a brand that really reflected and it was directed at males. We increased our outreach and marketing. We increased our in-reach, which I'll go into more detail because I think that lessons learned in hindsight, that was really where we did the most effective changing. We looked at our we needed to do more with our quality assurance, our QA, our staff training, clinic culture had to really involve men more, and our policies. And then we also needed to include male health topics as we went out into the community above and beyond outreach. We have a really active education department. I know not all clinics do, but we've always really encouraged education out in groups and different places in the community, classrooms, organizations, businesses. So we included more male topics in that effort. I'm going to go into the bullet points just a little bit more. Our focus groups really weren't as formal as they may sound. We found men wherever we could find men. We had a few men coming into the clinic, and whenever they would come in, we would actually ask them to stay a little longer with their visit, give us some feedback. How was the visit, what they liked, what they didn't like. We just really gave them some quick surveys at the end to try to start there and get the feedback from men who were actually using our services. But then we went beyond that to where else are we going to find guys who will come in and help us? Everybody knows men. Everybody has a male in their life. Everybody has friends. Our staff used spouses and friends of spouses and partners. We used people from our college here. We got some young men, some students to come in and do a group. So we saw several different ways of which we brought men in to get their feedback. We listened to what they had to say. We gave them every opportunity to tell us why they don't come to clinics. And what we realized was that what they were saying was, nobody's really ever told us we were supposed to come to clinics. Nobody's ever sent that message out that men need to take care of their reproductive health. Why would I go? And they really were kind of confused at the question sometimes. And then once they thought, oh, well, that does sound right, we should probably do that. Then it was, where will we go? Where is there? And there's just that Planned Parenthood, but that's a woman's place. And so there were these misconceptions in the community about why does a man need to come? And we're the ones who have to educate the community on why they need to come. And then we listened and implemented those suggestions. It wasn't, we were just not doing that, as a scholarly activity. We really did take to heart some of what they were saying and tried to figure out internally, how can we make changes? We really didn't say, well, we don't do it that way. Well, we can't really do that. Well, that's not possible. Well, that's never going to happen. we really tried to make changes. And that's really one of the basic, I think, lessons learned at the end, is that some of these changes we made in this project really came back to benefit us overall in future numbers and services. So here's another activity, if you all will sort of join in.
Before we go to an activity, there is a couple of questions in the chat.
Great.
As far as when you're talking about men's reproductive health, could you expound a little bit more of what's involved in that, as far as looking at, does that include prostate exams, testicular exams, etc., or are we just talking about STDs, STIs, and unwanted pregnancies? What do you mean by reproductive health?
So we are not a full service medical facility, and we don't cover all medical issues. And so our services, a male visit, if you will, would really be a basic, easy, quick screening for STDs, testicular exams. Hello?
Yeah, we still hear you.
Okay. Testicular exams. We don't do prostate exams. We do. We add just a basic, blood pressure, cholesterol, diabetes check. We do a history, and we do a general assessment, more of an interview, to find out what kinds of other issues they may have. We use a diverse resource list to direct them and refer them to other services they would need in the community. Anything from substance abuse to job training to homelessness. We had a really wide array of resources that we had collected so that we could give men that next step. But the visit itself had to be pretty direct and pretty easy and pretty quick. What we did realize is that they mostly, and this is rung true right till today, they mostly come in when they need an STD screening. We changed their mindset of don't come after the need, but come regularly to get those screenings, get that annual checkup, get that 3-month or 6-month checkup based on your risk behaviors. We would ask them to sort of be proactive. Instead, we were we're shifting the mindset to don't wait until something's wrong, but just like women, we come regularly, we do routine screenings and checkups, but they were basic and they are simple. And I will tell you, one of our biggest feedback from men throughout the whole time we started this is that men will walk away saying, oh, well, that wasn't so bad. Well, that was easy. And so they were really kind of comforted in that sense, and then they would be more willing to come back.
Okay, thank you.
Okay. Is there another question, or do you want to go to an activity?
No, we're fine to go move to the activity.
All right. So just as far as focus groups go, just assuming that you are, and it doesn't matter who you are, if you're an administrator or a clinician or a medical assistant or front desk, billing person, you are collectively going to try to help with this process. So someone's asked you, where can we find men? Can you bring 2 men out of your life, out of your community? Can you think of places you could find men? I'd like to know if people have ideas about that. So if you have any idea where you might find some males or a male to ask to come into the clinic just to get feedback from them, just to get them involved in the process of knowing what works and what doesn't work for them, where would you find those men? And I'm just throw some ideas into the chat area, if you don't mind.
We have local veterans organization. We have industrial work areas.
Oh my God, those are great. Oh my God, those are great. and in fact, yeah, that's how many, I don't know how many communities have colleges. We've done quite a bit of outreach and been able to get volunteers and use interns and such that are male through our university. Now, I know not every community has a university, but a lot of places have the community colleges, and we really reach out strongly with them, and we found some guys there.
So there's others that's listed: barbershops, local university, motor pool or automotive dealer shops. those places.
Even PTAs, because there are fathers who are involved in their kids' education. We can go to those organizations to ask for male involvement as well. Great, excellent. Thank you very much. And if you want to continue to put these types of comments in the chat area to help each other, Kamisha, I'm assuming that will all be available to them after the fact, and they can read through and get more ideas from each other.
That's correct.
Right, and that's kind of what I was hoping. Okay, so the focus groups, we wanted to know that what we were listening to and hearing, we would actually use and change. Then we got to the branding, and this was a huge thing for us. At the time we were Planned Parenthood, we heard the feedback that was just a woman's place to go. We created Male Central Clinic. It was a brand that obviously it was very simple, direct. It was sort of a masculine logo. It was just sort of this way of reaching and saying, men, you have a place, right? As we educate that you should go, here's a place you can go. And Male Central Clinic, it was not a separate place or entity. It was simply a name and a concept. It was a time and a place. And so we added the tagline, Male Central Clinic, because men need it too. That was sort of our slogan. And this was our front of our building at the time. And you'll notice that here we have the Planned Parenthood sign on the door, our hours and such. But over here, we added this Male Central Clinic. It was a time that just men could walk in and get services. It was a walk-in time, basically. It was from 3 to 7 on a Thursday. What we realized from a lot of our focus groups were that men worked and, they couldn't get there in the days, during the days. And so we did have to extend. We picked a day of the week. We extended our hours. We created that time to just let guys walk in. And that was their place. So MCC became an identifiable name. It told men they had a place to go. MCC referred to a time where they could come in. We realized over time, and it didn't take very long, that we weren't taking female appointments during that one chunk of time on a Thursday, thinking that men were uncomfortable coming into a place that would have women. We found out very quickly it really wasn't about being involved with women. It was just sort of the timing. It was more timing and being able to get in quickly, and that was their bigger concern. So we very soon after starting just Male Central Clinic, we would start to feed in a few female appointments as we needed to. If a woman could only come on a Thursday afternoon, if a woman had an emergency visit she needed on a Thursday afternoon, we worked them into the same place, same clinic, same everything. It was just that, they were all in the waiting area together, and it didn't seem to make a difference. But still, it was known that men could come in as a walk-in during that time. Anybody could make it, now we have evolved to where anybody can now walk in, anybody can now, male or female, there is no walk-in time. It's just collectively across the board all week. The evening hours were added just because we knew men really needed that extra time to kind of get to the clinic. We did have to do some scheduling changing. The front desk, all of our staff had to be able to be shifting from morning staff to afternoon to evening staff. That took some doing. And I put the but there because I was going to continue on to say that as it stands now, we don't necessarily need to make that differentiation. Okay. Our outreach and marketing, I personally, as an outreacher, as an educator, I would put a lot of emphasis on this. I think this is important. Obviously, we need to get the word out and get the message out, and they would then, start to come in. That was my mindset. So we were everywhere we could be with this male central image, with a new message that there was a place for men to go. We went to health fairs. We did a lot of university and community college events concerts. We are lucky enough to have the beach near us, and spring break was a big deal. Is a big deal for us. So we would do beach outreach. We would always reach out to radio stations wherever they might be doing. They would come and set up a live feed station outside of our clinic, and we would be able to just sort of throughout the day have people come by, maybe pick up a T-shirt or something like that, and they would just be, you know, on air, but they would be here at our clinic, just selling or promoting. And we did that with other well-known personalities you'll see down here. We reached out to like the car dealerships, the men that people saw in our community, maybe the TV commercials, people they knew already. We would ask them to kind of give us a shout out or be part of our promotion and just sort of, you know, talk us up, you know. We did information tables. So health fairs were around, but we went out and found places where we would just say, there may not be an event happening, but this, you know, people are walking by here right now. I mean, this is a pretty well populated place. Could we just set up a table here and put our information out and just kind of interact with the people that way? We went to gyms, tattoo parlors, barber shops, campuses, car shows. We actually got in touch. We do have an interaction with the urologists in town. We do have one particular urologist group. They do vasectomies. Going back to one of the original questions, they do vasectomies. So our funding can manage that, but we don't do the procedure in-house. So they would come to us as a clinic patient. We would see them. If they ask for information on a vasectomy, then we would then refer them to that service at another facility. We created some promotional items. We have hand sanitizers, koozies, we have keychains, we have male vitamins, and we do have these condom containers that they can have. We have sunglasses made up. Over time, we've collected a lot of different little items that we could give away. Our main giveaway for Male Central Clinic were T-shirts. We only had the funding that we would have for those kinds of things. But we changed it from just Planned Parenthood to add the Male Central Clinic. We did, like I said, utilized, we got interns and students, especially young men. We felt like if there was going to be sort of a mindset and a shift, it might come from the younger generation, the next generation of guys. So we wanted them to, right from the beginning, no, you're going to want to take care of yourself and you're going to have a place you can go. Okay, so an activity for you, and I think some of you may have already started in on this one, but where are other places in the community you could do outreach if you have the manpower really and the time and the staff to go out and outreach? Where are places in your community you think you might be able to set up an information table or hand out flyers or get involved in an event that's happening out in your community? And if you want to write any of those down in the chat area, that would be really great. Share it with the other.
So we have some coming in at this time. Some said the college, I guess that's in their area, gymnasiums of where you find men convening, signage out in front of the health department.
Yes, right. We're located in such a weird place that our front door is really facing away from where a main street is. So we really aren't on the road. You can't just drive up and see us. And so we would oftentimes go right out to the road and just sort of flag people in, or we had some of those little banners, the big flag banners that would, let people know where we were.
For our area where we are in Oklahoma, the rodeo was a place that was mentioned.
Oh, I'm writing that down. That's a great one.
Some says state fair.
Yes,
that's some
we have what we call Buck Days down here. And so it's about a week of like a big festival downtown and a parade and all of those things. One year, it really was a lot of work and we could only do it once. But one year we created a Male Central Clinic float for the parade. And the theme, because many of you have probably never been to Corpus Christi, but we have this huge bridge that goes over the intercoastal to here. And so our theme for our float was bridging services, bridging male and female services. And we had it all decked out with the male. And one other, I'll plug one other promotional event that we do that was it's very popular. About every other year or so, we try to put on a contest. It's a fashion contest. We ask the population to make dresses or make outfits, fashionable outfits, all made from condoms. And so we've had some really great response to that. We've had a couple of years where we've done those fashion shows, but that was a real big promotion, and that worked well.
Another one is community baby showers. I do know that we do that a lot around here. And sometimes the partner is present. So community baby showers.
I was going to say, marketing wasn't only to where the males were, but we had to go out and reach out to those places new, but we really brought the Male Central Clinic message also. And I want to move on because we don't have too much time. So let me just say, in reach was the next strategy bullet point. And I feel like in hindsight, our lesson learned specifically for our clinic was that working internally was really our most effective. It didn't cost us anything to make the changes necessary, but we really had to do the work to make the changes. So in reach was really just promoting, like she said, right outside our own clinic. And like someone, some of them were just sort of internal, but just external, right? We marketed mainly, we think our main thrust was when we marketed to our own female patients already coming into the clinic. During a visit, they were asked, what about your partner? Do you think, if you have a male in your life, a father, a brother, a child, a son, ask them if they've ever heard of this. Ask them if they would like to come in. I mean, it's a very easy process. And we got our women, they'd leave with our Male Central Clinic information, flyer, time, all of that. But I will tell you that a vast majority of our exiting surveys throughout the project, when we ask, how did you hear about us? Very few ever said radio, TV, or bulletin boards, out external marketing like that. Almost, well, to a majority, it was, oh, my girlfriend told me about it, or my spouse told me about it, or my, I have a friend and she comes here and she told me about it. So our own female patients became like our little army, I guess, as you will. And they took the word out, and we explained to them in their visits why it was so important to get men involved. What we did recognize in those discussions was that women come here because they understand the concept of family planning. Men come because they're taking care of their health. They didn't resonate with family planning. It was reproductive health. Yes, I can see that. Sexual health, definitely need to take care of that. Taking care of their health or taking control of their health were really important ways that we, would market the services in a way that men relate to. Instead of saying, do you exercise? We would say, do you work out or do you go to the gym? Because they see it differently. They just use different terminology. So we had to kind of tweak the way we spoke with men. I've spoken with my nurse practitioners saying, what is it that you do for males that make them so comfortable? Because we do feel like that men leave here feeling really good about their visits. And they were saying, we just have to meet them where they are. We just have to make it, address their concern directly. Don't offer too many other things they don't need or don't want. And then just sort of talk to them in terms they relate to. And those were ways they had to learn, slowly but surely. Guys will feel more comfortable when we can just talk to them like guys. The quality assurance, the training, the clinic culture and policy, I believe we're all, many clinics I know are already doing this. But we did exit surveys as all as all males left. They kind of gave us feedback. At 3 and 6 months, we would follow up and call them. We tracked those guys, and we just, we didn't stalk the guys. We tracked the guys, and we would call them and just remind them that they might want to come in for a follow-up visit, or find out how they were doing since their visit, or if they had any long-term feelings about what went on in the visit, any feedback they wanted to offer us. At 1 year, we always called them to say, this should be an annual thing. If you haven't come back already within the year, you might want to check in now, because it's been a year since your last visit. Staff was given more training on basic things like male anatomy, male reproductive anatomy. We know a lot about women's anatomies and all the terms, but not a lot of our staff, even our front staff or our, we all got more training in male issues, male health problems, STIs, HIV, obviously, and things like that. We practice cross training here because we're growing, but we're still a small clinic. But we have to be able to schedule and make shift changes so that days and evenings can be covered and things. And if somebody's out, or so as an educator, a community educator, I can still go up and I can work the front desk, and I can bill, and I can help here. So we're cross-trained so that we can spread out our staff in the best possible way to utilize them all. It also avoided this idea of territorial, like, oh, I just bill, I don't have to worry about that. That's not my job. I don't have to think about male health. That's just the clinic side. So we did, everybody bought into this process, and that meant everybody kind of did everybody else. We learned each other's roles so that we could assist. Our staff, our own attitudes, expectations, and stereotypes, we challenged those. We had a couple of clinicians who they were women's health clinicians. That's what they were trained, and they really didn't feel like they wanted to branch out into male services. It didn't make them comfortable. I can only think of one specific nurse practitioner that we lost in the process, because she just really wasn't willing or able. She just didn't have a feel for it. She just didn't buy in. And other than that, it just took longer for some than others to just sort of realize I have some stereotypes about guys, So I think there's an activity here I'd like to ask everybody. And I think this is a primary question. Thinking about everything we're talking about here, about stereotypes and belief systems and things, I want you to answer this question. Why are men not coming to the clinic? Like, what is keeping them? And please, try to think of anything you can and share it with everyone in the chat. I feel like that's a central question, because sometimes in the beginning, when we asked that question, we had a list of reasons why guys didn't come. We never really stopped to ask ourselves, what are we doing that men don't want to come, right? So it's a two-sided coin. I'm just curious to know if there are any answers.
So we have they're embarrassed, don't usually seek medical care. Some says not used to that routine / annual care, not familiar with it.
So it was really just sort of the mindset. It was like they really didn't know it. They didn't really even think about it. They kind of put it off. There were a lot of stereotypes we had that men just didn't want this kind of stuff, that they didn't feel like they needed it. It was like the woman's job to do it. It was misconceptions like that they just didn't want to come, when in fact, they worked, and our clinic times were just right when men worked, so they couldn't come. What we had to do is change our mindset to think like this. Men want reproductive health services, and men need reproductive health services, and men share in this responsibility for reproductive health in their own personal life, in their relationships, and in their families that they will develop. So that we had to accommodate them, and we had to kind of come to them if they weren't coming to us in essence. And I appreciate the feedback, because I feel like checking ourselves, and finding out what we've really been thinking all along may actually just be excuses to allow us not to do anything differently. So if we have to change, sometimes we have to ask ourselves, is it us, or is it you, or is it me? Right? Okay. Community education, I'm not going to spend too much time here. I think I've already said we really have always had a strong educational presence in the community, but we really worked out ways to add male health topics to our presentations out there, especially when it came to relationships, healthy masculinity and fatherhood and things like that. Male identity is right now quite popular. So we've been doing more and more of that with that. These are our final, I'm going to just try to wrap this up in the slides to come. And do we have time? We do. Everyone plays the role. Everyone in this agency, from the administrator to the person who wipes up at the end of the day. It's teamwork, it's creative thinking, it's seeing yourself as change agents and getting excited about a certain message you're trying to share. Administrators, from the top down, your expectations and the policies you'll set and the way that you'll organize and schedule and do all of those things really sets the tone, but you'll need to be flexible. Staff has to have the right knowledge and training to feel like they can work with men and not get a little uncomfortable every time they see one coming. Like, oh no, we got one. Staff puts forth an effort, and they follow up with these male patients that they already have. They make them feel welcome to come back. And everyone believes in the importance of the program, and that creates this synergy that I feel like we really did have in those beginning years to get this thing started and going. Right now, I would tell you that WMHS, Women's and Men's Health Services, that's our new name that we have adopted since 2011, we've just become totally integrated now. So we've really phased out, to a large degree, the male central clinic concept or the name. It really isn't, it's still sort of on some of our signage around outside and on the signs, but we don't have a separate Thursday walk-in clinic anymore. What we learned is, because that works so well, all days are walk-in. If we can see you right now, we will see you right now. And if you're a female or male, it doesn't make a difference. Everyone now is walk-in, see them same day. We do, since COVID, I will say, COVID has thrown some, us all into a spiral. But basically now we are actually asking for appointments more than walk-ins, but anyone can make an appointment anytime. Men are very comfortable coming anytime, as long as we can give them those additional evening hours. We now have Tuesday and Thursday evening hours, as well as the full day the weekly schedule. But both men and women can utilize all of those equally. And men have become aware and comfortable with that idea. The changes we made based on the fact that it was for males, the reason we wanted to do it was to get men to come in. But what we realize now is it really improved care for all of our patients, even the females. And so the way we operate has just been tweaked enough to where it works for everybody even better. And I just wanted to show you these numbers just to kind of show where we were and where we've come to real quickly. This was the 5-year grant time, 2003 to 2007. We would see females, several thousand females a year. And in each year, we were seeing very few, but you can see collectively, simply put, it grew every year throughout that project. Up from 4% of our overall patients being men to upward to 17. And that has held steadily. This was our most recent year that I just pulled up so I could just add to this presentation, really, was 2021 last year. Now we're seeing 14,000 women. And now we see 3,000 men. And this is an annual number, and that holds steady around 18-20% every year that we're seeing men. And so I really feel like, you know, I feel like I'm just sort of bragging about what we did, but I really do feel proud of what we did. I was not an administrator or the project director. I wasn't the one setting policies. I was just a clinic staff like all the other clinic staff. And we all came together, and I feel like we really kind of got excited about it and made it work. And it still today makes our clinic a better place. And so I'm going to just skip over that last slide because I think I updated it with the actual numbers. I did want to kind of share, if we have a minute. Do we have a minute? You know what? Before I do this, let me just, I'm sorry, Kamisha. Let me just ask if anyone there has any general questions they would just like to ask or throw out there.
As those questions, as those questions come in, we do have a little time for you to show the videos.
Okay, so while, yeah, if you all will be thinking of questions you might want to ask, you can be watching one of our commercials. This was one, I think, from a while back. Let's see. And I'm hoping this just generates directly to it. Browse YouTube and go.
The odds of getting eaten by a shark, 1 in a million. The odds of getting an STD, 1 in 4. Don't ignore the odds. Get checked. Women's and Men's Health Services. Make an appointment today.
Can you do the one that's also
Oh, hold on. I'm so sorry. I apologize. So sorry. I'm really not good at the sharing. Which one, Matt, sir?
your advertisement with the men, or yes, the commercials.
Yeah, this one is more recent, and I'm not even sure we've actually put this out yet. This takes us to our website, and then this particular, see if we can play that.
This is Mark. Mark went out late, had some regrets, and has a story to tell.
I knew I messed up the minute I left. I'm sorry, I gotta take this. Hey, I'm at that acting gig. The one where I play a guy who has an STI? A sexually transmitted infection. No, I don't have an STI, my character does. It's to bring awareness. Because it's important? Did you know 1 in 5 people in the US have an STI? Yeah, that's what they told me. It freaked me out too. I gotta go, man. They're staring at me ugly. What? Yeah, you should probably get tested. It's quick and easy. Okay, bye. Okay, where were we?
Don't ignore the odds. Testing is quick, easy, and free. Call us today or book an appointment online. Women's and Men's Health Services.
All righty. And what is this? This was just, I'm going to share this as well as image. Can you all still see these things? Yes?
Yes.
Okay. So this is, this was our original, when we did, develop the Male Central Clinic brand and the image, we gave it its own website. And so this was what that looked like. It sort of was a very masculine, this red, black, white kind of theme. And so again, no longer, we don't have it up anymore simply because we've merged into this one unified presence as Women's and Men's Health Services. So, so that was that. And I think that's everything I have. I'd love to take questions and just have a discussion if anybody wants to pop in.
I have a comment.
Hold on, Ira. I don't see any particular questions, but there has been comments going throughout. When you talked about the reason why men might not be coming to the clinic, one thought was perhaps too much negativity associated with males. Maybe we can address the issues with that and place a positive spin. And then when you mentioned about having males work in the clinic and them seeing themselves reflected in some of the workers, A comment was made that that was a big one. As a male working in a clinic, I can say there was a feeling when I first came into that. I was a female, I was in a female only area, and I've worked predominantly with women for over a decade. So changing the narrative of who they see and identify within the clinical setting is important.
It's so true. I mean, I can tell you that when I first started working, I thought I was coming to a women's health clinic. That's what Planned Parenthood represented to me, even coming as here to, as an employee. And through this project, it just opened my eyes to what reproductive health really meant. And it didn't really just relate to women. That men are such an important, the idea that for, every year you could see thousands of women come through your clinic. You can treat hundreds of STD cases. If it's just women and they're going back out into the community, it's just a revolving door unless they understand that men are also equal, they are equal partners in this process. And I think that whoever he was or she was that said, changing the narrative and not coming down on men. I feel like as women, find empowerment, we can't take it at the expense of males, right? And putting them down. So we do have to reach out to them and say, we need your help. We need you to be our partners. We need us to, help each other. When we help ourselves, we help each other, and then we help our families and our communities. I feel like that is just such a simple but true equation.
Cinda, thank you so much for taking time to share with us and sharing your clinic's success story. I think that there are things that you've shared that are new, as well as some things that we're still dealing with, but it gives hope to see you've branded it. Started out in branding males, but now it's inclusive, that's incredible, because it's one thing to brand something, it's another thing for something to become, I want to say, mainstream and a part of that. And so, and you also summed it up in saying, though you're a health educator, the whole clinic came together, and there's this cultural training mindset. So thank you for sharing.
I don't know if there are any nurse practitioners or, but here with us, but I will say, when they come here, you have authority, and you are a really important part of the marketing of, reaching out to males as well. It isn't just, a basic visit. It's talking to them about these concepts, right? But I do want to just say what we did here, we tried to do at a very grassroots local level where it wouldn't be expensive and it wouldn't be overwhelming for staff or time. So I feel like, whoever you are in Oklahoma, whatever setting you're in, I feel like you can do more. We can all do more. So keep thinking of new ways to reach and include men, bring them in. Yeah.
Cinda, if people want to reach out to you, what's your email?
It is clebus@wamhs.org. I don't think, I want to just see if I have it. I'll go right back to the beginning.
At W what? H?
Oh, I don't have it. It's clebus, Lebus,
Okay. Case you got.
at WAMHS, Women's and Men's Health Services.org.
Our time is up. And so thank you for the time that you've spent with me prior to this. We've been on a journey together for the past 3 months, talking with each other, and thank you for giving of your time.
I able to condense it down into the time we needed, but I'm glad we got as much out as we could in this time. Thank you so much for having me.
Well, thank you too. I'm from South Texas, and so when I met Cinda, it was a great thing to meet someone from my part of the world where I grew up. So thank you so much.
Thank you. Now, do I hang up will that stop my sharing?
Yes.
Thanks. Thank you, everybody. I appreciate the time.
We would now like to move into our next presenter. Let's welcome Julie Milburn. She's an advanced practitioner, registered nurse. She is the chronic disease coordinator for chronic disease prevention and health promotion here at the Oklahoma State Department of Health. Julie will focus on understanding the process of chronic disease on health and how to manage it for an improved quality of life. Thank you, Julie, for joining us today.
Thanks. I'm going to try to share my presentation. I am not very tech savvy, so if things go wrong, I hope I have backup.
You do.
Like Ira said, I am a nurse practitioner by trade, and I did spend 20 years in the military working in family practice and internal medicine. So I had the advantage of having a pretty much an audience that had to come in as far as men's health goes. They didn't really have a choice. I did see them slack off a little bit once people retired, when they weren't mandated to do their annual physicals and all that. But the military does have a fit to fight kind of mentality. So if they want everybody to be healthy, and they don't want any extraneous problems coming up if they need to deploy somebody rapidly. So I guess I'm kind of on a different spectrum when it comes to men's health a little bit, because that was kind of always something that they had to do. Anyway, I tend to talk a little bit fast, so if anybody has questions or anything like that, just feel free to interrupt me. And I think I'll go ahead and get started. Again, it's obviously Men's Health Month, and we did this through the Chronic Disease Prevention Service, and it is all about the fellas, I guess, this month in June. So what is the purpose really of Men's Health Month? And it really is to heighten the awareness of preventable health problems and encourage early detection and treatment of disease. So the four main caveats are really awareness, prevention, education, and family. So if we can kind of remember those four things, then we're on the right track. The month, it gives healthcare providers, public policy makers, media, and individuals just an opportunity to encourage men to seek regular medical advice and early treatment for disease and injury. And June 17th is Wear Blue to kind of help promote that. There's just a few quick facts. Probably everybody already knows these to some extent, but I'll just kind of briefly touch on those. The life expectancy for males is 5 years less than women. The leading causes of death in men, the number one is heart disease, and the number two is cancer. Men are 4 times more likely to commit suicide than women, and when they do attempt it, it is much more lethal. Approximately 160,000 men are diagnosed with prostate cancer every year, and approximately 30,000 will die from prostate cancer. And 1 in 2 men will develop cancer, which is a very high statistic if you think about it. And then men make half as many physician visits for prevention as women, which is probably why 1 in 2 will die from cancer. And men are more likely to be uninsured than women, which is an interesting fact because usually they are I guess the financial breadwinners of the family. So it's interesting that they're more likely to be uninsured. Just to touch on vaccinations for the guys, flu shots every year, tetanus booster every 10 years, the DTaP booster, unless they are certainly have one as a teen or a preteen, which nobody can ever remember that. And I think I don't really know much about maternal health or doing the babies, but I think pretty much that if you're being around babies or you have a baby that's getting ready to be born in your family, that's something that your docs recommend getting updated with. The HPV vaccine, if you're younger than 26 and you haven't received it yet, hepatitis B, hepatitis A, and then shingles at age 50. And I think Joyce had told me that this was mainly geared toward men in their reproductive years, but I said, you know what? I've had many a men that have come through who have been in their 60s that are like, hey, me and my wife are getting ready to have a baby. So I think men are pretty much in their reproductive years all the time. Let's see. Routine screening tests, we'll touch on those. There's several. And this is just from my practice. It's not an entirely inclusive list, but these are the things that I always touched on with my patients. So blood pressure, testing at least once every year if you have normal blood pressure, which would be anywhere from 120/80 or below. So the normal blood pressure standards now are basically less than 120 and less than 180. So if your blood pressure, if you're testing your blood pressure and you're somewhere in the 120 to 129 range systolically, which is your top number, and less than 80, then you're already considered to have elevated blood pressure. High blood pressure stage 1 has been listed from 130 to 139 with that top, with your systolic number, and 80/89 with that diastolic. And then high blood pressure stage 2, 140 or higher, and then a hypertensive crisis is over 180. So a lot of people will just kind of go into the stores, at the drugstores, and check their blood pressure. Probably those aren't always that accurate in those little machines. But if people will, when they're going to the doctor or they get someone to check their blood pressure, I wish the dentist would check them more because they find a lot of hypertension sometimes. But everybody just kind of verify that when you are testing somebody's blood pressure, make sure you have the right cuff size. I'm not a real big fan of the automatic blood pressure cuffs. I kind of like the manuals myself, but make sure you have the right cuff, make sure your patient's legs aren't crossed. And when you bring them into the room, just kind of let them relax for about 5 minutes before you start taking blood pressures. And I know when we get patients in clinic, we're just like, let's get them in, let's get that get them checked in, have them sit down. And they really don't have a time just to kind of sit there for a couple of minutes and relax. And then make sure they're just keeping still and quiet while you're doing the blood pressure readings. Another routine screening test is cholesterol. So every 4 to 6 years, if you have heart disease or diabetes, probably you should be getting that every year. And depending on what your levels are, you could go your doc could recommend having those things tested every 6 months if you're on medications. But your more desirable levels are less than 200 is considered desirable. Over 200 is borderline, and over 240 is considered very high. The HDL, which is your good cholesterol, you don't want that. That's the one you want higher. So you don't want it to be too low, less than 40. Satisfactory is anywhere from 60 and above, or somewhere around 60. And then if you're above 60, you're really considered desirable at that point. The LDL is that bad cholesterol. We want that to be about 100 or lower. And then anywhere over 190 is considered excessive. Again, triglycerides, that's what you're really the fatty stuff that kind of hangs out in that blood because it's just too big and fat to filter. And we want that to be under 150. And then, so those are good numbers that you always can kind of keep in the back of your mind. Height and weight screening is something you need to make sure you're doing annually. And check your BMIs. And that's kind of where you're at with anything over that in that 30 range is considered obese. And then 25 to 29, you're definitely in the overweight stage. So just kind of make a commitment though, when you're talking to your patients, kind of if they want to get started on weight loss, we should always be kind of bringing that up. To help them make a commitment, help them set some realistic goals, identify some resources for information and support. There's the extension services have massive amounts of classes just to go over with that. So if any of your patients are near those, they have a lot of good information and it's free. And then just kind of, there's kind of the 3 R's: reflect on, help them reflect, and replace and reinforce. So reflect on those eating habits and their goals, what their goals are, what they're eating. Replace their unhealthy eating habits with some better ones, and then just kind of reinforce all those habits that they're trying to get, and just get people to be active, daily physical activity, and on that. So routine screening tests, sexually transmitted diseases, kind of go through that. Any sexually active men who have unprotected sex, gay men, or any partners that they don't have a history on, they should be screened at least yearly for chlamydia, gonorrhea, and syphilis, and then at least tested for HIV at least 1 time. Hepatitis B, if they're at high risk, if they're intravenous drug users, medical workers, anyone who has maybe can contact with blood products, or traveling to foreign countries. Hepatitis C, if you live with somebody that has had that, or you've had blood transfusions or things like stuck by a needle. Those are important screening tests to get done as well. Diabetes screening. And I don't know if anybody has any questions or anything, just please, like I said, go ahead and stop me, because I talk fast. Anywhere from age 40 to 70, you should be screened if you're overweight or obese. Any risk factors for type 2 diabetes or heart disease: if your blood pressure is higher than 135/80, if you use any type of medication to control your blood pressure, then you definitely need to be getting screened at least once a year. If you're making regular doctor visits, then they may have you get screened a little bit more frequently. If you want to know what your risk assessment is, the CDC has a pre-diabetes screening test that you can go online and take. It's basically to know your score. So if you're 3 to 8 points, you're probably at low risk, but you need to make sure that if you're overweight, you're losing weight, you don't use tobacco, trying to watch your meals with low fat, fruits, vegetables, whole grains. And if you have high cholesterol, high blood pressure, you definitely want to be tested again for diabetes. And if your score is 9 points or more on that test, then you do have prediabetes, and you definitely want to make an appointment with your provider. And that's just kind of a glimpse of what the prediabetes screening test, oops, probably want me to fast forward that slide so you can see that. Having some technical difficulties here. And right there is the prediabetes. So if you have your A1C, which is the hemoglobin A1C, and that will give you a 3-month snapshot window of what your blood sugar has been doing over the past 3 months. And then fasting blood sugar, less than 120, less than 126. 120 is for your glucose, or 200 is for your glucose tolerance test. And if you're pre-diabetic, you're 5.7 to 6.4, fasting glucose 100 to 125, and your tolerance would be 140 to 199. If you're normal, you're under 5.7, your blood sugar is 99 or less, and your glucose tolerance is 140 or less. And if you want to go ahead and take those tests, there's the website for the CDC, and then the State Department of Health website as well. Other routine screening tests are the prostate specific antigen, or the PSA test. And there is a lot of controversy about, should providers do this testing or not. I will say that most medical groups don't recommend it, but the two that do are the American Cancer Society and the Medical Urologic Society, whatever their society is for urologists. But I can tell you personally that this is a test that I would do every year on the guys over 40, because I've found several patients that had prostate cancer. So, but these are some of the things that can cause your PSA to be elevated. So just because you have an elevated PSA does not necessarily mean that you have prostate cancer. Just an enlarged prostate can cause your PSA to be elevated. You could have prostatitis. You could also obviously have prostate cancer. If they had recently had any sort of an ejaculation or sexual, intercourse, anytime you had to do a digital rectal exam, you can make the PSA elevated, or just riding a bicycle. So those are questions that I always asked before we did that lab testing, because it's a simple lab test to do that can really help screen for that problem. Colorectal cancer screening, again, this is something for adults basically 45 to 75. But if you do have a family history of colon cancer, any rectal bleeding or anything like that, then it's probably a good idea to get screened. There are some tests that can be done basically that don't require you to have a colonoscopy. That's the stool guaiac test, which is just basically they can do that in the clinic, and they just take a sample of stool from a rectal exam. There are 2 home tests that can be done, the fecal immunochemical test, which is the FIT test, and then there's a FIT DNA test. These are home tests, but I'm not aware that insurance pays for them. They run about $50 to $100. And basically, with the FIT test, you would take a small sample of your poo, and you'd send that away to the lab. The FIT DNA test uses biomarkers, and that one requires you to submit an entire bowel movement. So most people don't do that. But the flexible sigmoidoscopy or flex sig, that one is basically every 3 to 5 years. They don't do a visualization of the entire colon, which is a limitation for that test. It just does the rectum and the lower colon. And then you have the colonoscopy, which is every 10 years. And then based on results, you could be recommended to come sooner based on your initial screening exam. And then they have the virtual colonoscopy, which is via CT scan. The other ones are lung cancer as a routine screening, and that would be for adults 55 to 80 who have had a history of smoking, usually 30 pack a year smoking history, so a pack a day for 30 years, or if they've done 2 packs a day for 15 years, etc. Or if you currently smoke, or if you've had a history where you've smoked within the past 15 years, then that's always recommended. And it's just good to do it's just a, low dose CT. And if you catch cancer early enough, you can have a better chance of curing it. The other test is just a one-time test again. And like I said, I've had patients in their 60s and 70s that have had their wives get pregnant. But so I always throw this kind of thing in too for abdominal aortic aneurysm ultrasound. And that's just for anyone who's ever smoked in their life. Okay. The next is this routine screening for depression. And about 15% of men will suffer from depression or mental illness, but they don't ever tell anyone. And like I said, that's where they're 4 times more likely to commit suicide, and it's always more lethal. But if they're feeling, if you're around somebody or you're having feelings, change in appetites, change in sleeping, you don't feel enjoyable with those activities anymore, decreased energy. There's some screening tests. These, I just listed some of the most popular ones. It's certainly not an all-inclusive list, but the PHQ-9, the PHQ-A, the PHQ-9, and the CESD. And those are just a few of the screening tests. Skin screening, always important to do, especially we like to hang out in the summer sun all the time, especially in the nice summer weather. And just making sure you tell your patients about sunscreen. The blood work, I think everybody should probably get these done annually, especially after I started annual labs about at 35 mostly, and then depending on anybody's medical history, I would probably do that sooner. But cholesterol, complete blood count, or at least a basic metabolic count, thyroid panel, and then liver enzyme markers, A1C, AST, ALT, and fasting glucose. And then behavioral counseling for prevention. Anybody that comes in, if they're overweight or obese or have any sort of CVD risk factors, always important to do some counseling for that. Routine screening if they were statin user. Cardiovascular disease, if they had met all of these criteria, 40 to 75, hypertension, diabetes, high cholesterol, smoking, 10-year risk of a cardiovascular event was 10% or greater with the CVD risk calculator, then it's probably important to go ahead and put them on a low-dose statin to help with the cholesterol. And then latent TB. And this is always one, you have to base this on your population. I did have a tour of duty in South Texas where we had a big migrant population. So latent TB screening was always something we did. And then that was, the TB time tests were always something that the military required anyways. So that was always part of our TB screening. And then substance abuse screening, you always want to ask about alcohol, tobacco, and drug use. And then if they have roommates or they live with somebody that smokes, that secondhand smoke screening, always important because it can still cause cancer, heart disease, stroke, and even just brief periods of exposure to secondhand smoke can, do damage to your heart and your blood vessels. And then again, tobacco screening. We always provide behavioral interventions, any approved pharmacotherapy for cessation to adults who use tobacco. Kind of pulled this from the Oklahoma tobacco line, but they did spend about $1.6 billion on healthcare costs in 2009 alone, just for tobacco-related diseases and issues. 1.6 million from the CDC for tobacco prevention and control activities just in fiscal year 2020. About 18.9% of adults smoked cigarettes in 2019. About 7,500 will die from smoking-related illnesses. And I thought this was just kind of an interesting factoid that when the TIPS campaign, the 2020 TIPS campaign was out, the Oklahoma State Quit Line got almost 18,000 calls between March and October just during their campaign. So that was pretty impressive. And then we always talked about anticipatory guidance or psychosocial screening. And again, this was just questionnaires mostly that we used, and it can be questionnaires that you guys can do as well. But again, touching on diet, vitamin D is a big one, especially for people that live in areas with they may not have a lot of sun exposure. And that's a simple lab test you can do to see if someone has a low vitamin D. And calcium, always recommended for people 50 and older. And then again, obesity screening. Sleep habits, this is a big one, but basically just talking about good sleep hygiene, getting a consistent sleep schedule, regular bedtime rituals, regular exercise, healthy diets, limiting caffeine and trying to avoid nicotine, avoiding alcohol when you sleep. And then a lot of people would say, well, I need my wine or whatever to go to bed, but they don't really realize that even though it's just slowing your brain activity, but it's not slowing you. So usually people don't get good sleep if they're using an alcohol as a sleep aid. Keeping naps short. If you feel like you have to nap during the day, then try to limit that to no more than 30 minutes because you're just kind of screwing up your sleep debt at that point. And it's kind of making a withdrawal from your bank in essence. Aspirin use, always recommended for people anywhere from 50 to 59 when they had a CVD risk score. and they weren't at risk for increased bleeding. And but you got to kind of gauge that, because you really have to do that for about 10 years for it to show really any advantage. And so if your folks aren't going to get to do it for 10 years, then there's probably not going to get a whole lot of advantage out of it. Sun exposure, again, we're talking about the sunscreen and the skin lesions and skin screening. And then the other one I'll touch on that doesn't get a whole lot of props is testicular cancer, and mostly between the ages of men 15 to 34. So always a good idea to do the testicular self-exams for men and teach them about those, because they're probably going to find those, and they may be more not really willing to come in and talk about that to somebody, especially a female provider. Family planning, again, the military did a fairly good job on this, because we got people when they came in for basic training or officer training school, because we didn't want them to, we wanted to keep them in the fight, fit to fight again, and mostly keep them free of STDs. And when they're in school, they have a tendency to go out in the local community and maybe find girls that they didn't have a history with, didn't know anything about. And so we're trying to prevent unwanted pregnancies. So condoms were always available to these guys. Again, talking about when you have patients that come in, just talking about preconception health. You know, are you married? Are you planning on having a family? Do you have a girlfriend? You know, what's your family planning goals, and trying to help them meet those. Exercise, again, 30 minutes a day, 5 days a week, with at least 2 days of strength training and aerobic strength training, as well as Tai Chi. For people older 50, that can be a great thing for them to do, because they feel like they can do that without overstressing their bones and their joints. And if you have if they have any type of cognitive decline, I would really avoid memory supplements, because I don't think that really helps them too much. And there has been some studies shown that doesn't, it actually may cause some problems in the long run. Oklahoma has some Heart Healthy Trails. There's Heart Healthy Trails apps, and the Oklahoma Tourism Parks and has walking trails. They have an app as well. So if you like going to the lakes, or you like going to the city parks, then you can download. There's some apps that you can download, and that will show you exactly what type of trail it is, how long the trail is, and it'll give you a little map of that. And then a lot of communities, a lot of local library communities systems do story walks, where there's books or poetry or paintings that you can kind of walk around the trail and kind of get an education as you get exercise. And this is just a couple of flyers that they can be put in exam rooms and social places where people gather. And it just kind of gives a breakdown of, you know, 7 steps to a healthier heart. And then again, the men's health testicular exams, again, very important, because these are typically missed in guys. They just typically don't do these. But one of the interesting facts about one of the risk factors for developing testicular cancer, now that, you know, marijuana is a big thing, is increased risk for testicular cancer for folks that use marijuana. And they don't really know why at this point, but there is a correlation between the THC in the marijuana and that trying to cause some sort of hormonal disruption. So safety issues, we always talked about domestic violence, intimate partner violence, domestic violence in the home, domestic violence with your girlfriend or your male friend, and then screening for that and trying to get them to interventional services. Smoke and carbon monoxide detectors in the homes, firearm use and safe storage of those. And then again, protective and safety equipment. I'm not sure why, but I've always found that men are more or less likely, I guess, to use bicycle helmets or any type of those safety equipments when they're biking, skating, skiing, and seatbelts too. I often feel like men don't like to put those seatbelts on, and I'm not sure what that is about, but that's just my personal observation. And then there are just a few personal care apps, health related. They have the Medisuf pill minder tracker, the Apple Health app. There's several workout apps. Home workout, Fit On, 30-day fitness, the Step App pedometer, and there's a few personal care apps. MyFitnessPal, Headspace is more for meditation. Sleep, which that is correct, SHLEEP, and that's for sleep cycles. Luminosity is for brain health, and MyPlate Calorie Counter. Those are just a few of the more popular ones. I think they're out and about. And then that is all I have. And then again, just June is Men's Health Awareness, Prevention, Education, and Family. So like I said, I talk fast. So if you guys have any questions, I am finished with my presentation. So I hope you guys kind of gleaned some information out of that. And thank you for letting me share.
Hi, Julie. There was a question asked if there could be digital copies of the flyers that we share.
Yeah, I can definitely get those copied and forwarded to you.
Okay. All right. Thank you.
Julie,
Yes, sir.
thank you for joining us today and giving us insights. Thank you for the wealth of information going through a lot of different screenings and ways that we can be aware of.
Ira, can I ask one more question?
Sure.
There's also a question in the chat. Is there a publication for the link to testicular cancer and marijuana use? I guess there's more information that's wanted. They're wanting to know about that.
Yeah, there are different research studies. Again, the one I pulled off of was from the Mayo Clinic, but I'm sure there are different, you can kind of Google just pretty much anything, but again, there's not a lot of, they haven't found what the exact correlation is. They just noted that when they've done the screenings and the questionnaires, when young guys have developed testicular cancer, that there was a commonality of marijuana use with that. And again, what they're believing right now is just the THC in the marijuana is causing some sort of hormonal disruption there. But again, I pulled my information from the Mayo Clinic, but there may be other, obviously there's other places that you could get that information from as well.
All right. Thank you, Julie.
Sorry, any other comments that participants would like to ask or share? Okay, so Julie, yes, thank you for joining today and sharing about the screenings and ways to improve the quality of life among the men in Oklahoma. Just a reminder that all attendees are to complete the verification of attendance by way of the individual sign-in form located on SharePoint. This also includes staff who watch the recording later. And again, for Oklahoma City, County Health Department, and Tulsa, please see your program lead for the sign-in sheet. Future training dates in September. On the 8th of September, we have the maternal health and infant health outcomes. October 28th, we will have the family planning program updates, which is a mandatory training. November 11th, we'll have the community participation, outreach strategies, and quality improvement recording. Thank you and have a great weekend.